Hello friends. I'll be giving a brief overview on this very broad topic, pharmacokinetics and pharmacodynamics of ICU drugs. So as you would agree, this is a huge topic, but it's a very important topic for all our ICU trainees. And this has been asked as a question in DrNB. So it's a broad topic. So giving you an overview, I think it possibly tries to encapsulate the key aspects of this particular topic. Uh, so when you are writing a answer for these questions, it is imperative that at least the salient aspects of these topics are elucidated when you are writing. So I wish to acknowledge my trainee, my colleague Dr. Pradeep, who helped me develop this content. So the topics that I would be covering is for all of us, when I ask this question to our trainees as to what these are, the answers tend to be a little diffuse with lack of a bit of a clarity on the key aspects. So certain things, at least we need to have some clarity as to what we understand by pharmacokinetics. Uh, so, so I'll try to simplify this through the narrative. So there are three important components of pharmacokinetics. So basically, pharmacokinetics is when the drug is administered, it attains certain concentration within the body, and there are multiple factors. There may be factors related to the drug, and there are factors related to the patient bar host, which determines the type of concentrations that the drug achieves. And that whole concept is pharmacokinetics. And then we'll see how it is practically applicable. So VD is volume of distribution, or sometimes we use the word VI. And CTB is the total body concentration, and this is the half-life. And even in half-life, there are three half-lives. So there is a distribution half-life, then there is an elimination half-life, and there is a general half-life. So I won't be talking in detail. There's another video, you can look into all that. Then we need to understand what is pharmacodynamics. So simplistically, pharmacodynamics or biophase is once the drug is administered, it has certain effect on the patient. And that effect is determined by the metabolites of the drug. So the metabolism the drug undergoes and the elimination, both are influenced by certain basic functions of the organs. And the biophase is the target at which the drug is acting, and the effect it produces is termed as biophase. So pharmacodynamics is predominantly, it's a dynamicity, it's the metabolism of the drug and the elimination. That process is called as pharmacodynamics. I'll talk a bit on dose response. So this is important for critically. Why PKPD is important for intensive is because a critically unwell patient has a profound bearing on lot of changes that happens in the body, which influences the potency of the drug. So we'll briefly look at how this has an impact on the PKPD, how the critical illness has PKPD, how circulatory shock has a bearing on PKPD, how liver failure has a bearing on PKPD, and SIRS, because these are the typical sort of a cohort of patients we see, and we need to be aware as to how this influences the certain characteristics of the drugs. And we looked into very briefly on the principles of antibiotic dosing, and then summary and take home message. So these are some of the components that we'll try to cover. So when we talk about PKPD relationship, as I said, pharmacokinetics is once a drug is administered, the dose of the drug and the concentrations it attains is called pharmacokinetics. So if this question is asked, one should always write this correlation, dose, concentration, and the effect of this drug on a individual host or the patient. So pharmacodynamics is the concentration that is attained by the drug and the effect that it has on that particular individual is the pharmacodynamics. So simplistically, PKPD is dose, concentration, and the effect. So that is the whole relationship. Dose, concentration, effect is the PKPD. And these constitute the whole science of the drug and its effect on the body. And as you see, this is a very nice diagram. So one needs to remember ADME, which is pharmacokinetics deals with absorption and distribution of the drug. And the pharmacodynamics, the green one, you look at the metabolism of the drug and the elimination of the drug. So as already elucidated, so when we talk about absorption, distribution, metabolism, there are certain terminologies like volume of distribution, total body concentration, and half-life that we need to understand. So we'll talk a bit on volume of distribution, which is terribly important. Why it is important is most of our critically ill patients have increase in the volume of distribution. So simplistically, volume of distribution is when the drug is administered into the body, it gets dispersed within the given volume in an individual. And that volume can be the blood volume, it can be the fluid volume, it can be the extracellular fluid volume. It gets dispersed. And the amount of volume that is there for the drugs to be dispersed is the volume of distribution. Why this is important is in critically unwell patients, most of our patients have higher volume of distribution, which means the potency of the drug, especially the water soluble drugs, can be low because you have a high volume and the drug concentration, the concentration is lesser. So the potency of the drug can be lower, and that is why the argument is where you may have to give a high dose of drugs in certain situations. So volume of distribution, it is the dose of the drug that is given divided by the measured concentration that it achieves in the given volume. So again, the loading dose, DL is the loading dose, is determined by the volume of distribution and the concentration of the drug. So these are some of the technical sort of derivatives that you need to just bear in mind. So the volume of the loading dose is determined by the volume of distribution that the patient or the host has and the concentration of drug that is achieved. And there's something called steady state volume, which is the larger volume after drug distribution throughout the body. So these are all certain technical nuances. If you can, you remember. Otherwise, just bear in mind what is volume of distribution. If you remember that, that's good enough. It is the volume in which the drug concentration is attained, and that is calculated by the dose of the drug divided by measured concentration. And the rate of drug administration is equal to rate of drug element. These are some of the derivatives that one needs to keep in mind. So when you have to explain volume of distribution, the simplistic way of explaining is to just put this diagram. So this is the drug. And suppose this is the human body with the amount of volume that is there. Suppose we take for hypothetical reason, there is 1 liter volume within. So if you have a water soluble drug, so if it is dissolved in this whole volume, then the concentration that it is attained is low. As you see, it is 1 milligram per ml for one gram of drug that if you give. So the volume of distribution is 1 divided by 0.001, that is 1000, which means there is a huge volume of distribution for this given amount of drug, which is 1 milligram. But if you have, suppose, a lipophilic drug, and if you have this high concentration, then it becomes 100 milligram per ml. So where you have a drug which is concentrated within this small volume, then the volume of distribution becomes much smaller here because it has only this small concentration. If it is a lipophilic, where it is lipid soluble, so the volume of distribution is very small. So if you have a water soluble, the volume is larger. So the volume of distribution also, you have a large volume in which the drug has to be dissolved. So if it is a lipophilic, you have small amount of fat, so the volume of distribution is small. So, so the potency of the drug will be dependent on this concentration. So that is our understanding. So volume of distribution can best be explained with this sort of a schematic representation. And as I said, most of our critically unwell patients will have high volume of distribution. And generally, hydrophilic drugs, which are water soluble, they tend to have a large volume of distribution. And many of the ICU, like amiodarone, is a typical example of hydrophilic drug where it can really have a large volume of distribution, and multiple doses of amiodarone can be given to attain the desired effect, especially in critically unwell. So that's what it means. And typically, any patients where there is lot of capillary leakage, so then there is lot of extra fluid on board. So it means intuitively you should know that the volume of distribution is large in these patients. Or if you have third spacing, so most of our ICU patients will have a lot of extra extravasation of the fluid. So which means whenever there is volume is large, and if you are giving a hydrophilic drug, then the dosage has to be more to accommodate for this, to attain the desired concentration for this hydrophilic, because there's a lot of volume within the body. So that is our understanding. Or suppose you are resuscitating with a lot of IV fluids, like you have a trauma patient or a septic shock patients where you're giving a lot of fluids, then the desired concentration that you need to attain is with a higher doses, especially when you're using hydrophilic drugs. And I'll talk to you what are the hydrophilic drugs. But if you're using lipophilic drugs, then the volume of distribution is small because the fat does not expand. and the drug attains that desired concentration of the potency with the prerequisite dose that you have in body. But if you are using hydrophilic drugs, you have to use much higher dosage in these situations where there is a lot of volume. And suppose even patient having pleural effusion, ascites, the volume of distribution is large, and Burns patient have a larger volume of distribution, or someone who is an extracorporeal circulation. Because if your patient is on dialysis, you would be administering the replacement fluid. Or if you have patient on ECMO, or if you have patient on any extracorporeal circulation, so the volume of distribution will be higher. So that is something you need to keep. Or someone who has large surgical drains. So these also have volume of tissue. Just remember this picture. So these are typical ICU situations where you have a larger volume of distribution. So now importantly, this volume of distribution is important in hydrophilic drugs, which are water soluble drugs. And one needs to know, all intensive care specialists need to know what are the hydrophilic drugs. Very simple to remember. Remember with an acronym ABG. So aminoglycosides, they are water soluble. So which means in ICU, you have to give a high dose to attain the desired concentration, especially when the volume of distribution is large. You remember ABG, beta lactams. So it's very simple, isn't it? So in ICU, we tend to use carbapenems, we use penicillins, cephalosporins. So all these are water soluble and they need to be given in high doses to attain the desired concentration. That's why you would see not much of dose adjustment would be there, especially when they're on dialysis or in critically and even in patients with AKI, because these have a large volume of distribution. Remember ABG, G is glycopeptides. So these are I'm in this particular talk, I'll be talking more about antibiotics and PKPD. So hydrophilic drugs, remember with an acronym ABG, and these are the ones which have large volume of distribution where high dose can be given and not much of dose adjustments may be needed because of their large volume of distribution and their hydrophilic. They have large volume of distribution. And another characteristic of hydrophilic drugs is they cannot act on intracellular organisms. So that is another characteristic. And most of the hydrophilic drugs, it's because it is water soluble, excretion happens through the kidney. So the excretion is through the kidney. So these are some of the characteristics of hydrophilic drugs. Then how about lipophilic drugs? So lipophilic drugs are, as the name suggests, it's a lipid soluble drugs. Volume of distribution that is needed is small because they are lipid soluble. So remember with LRT and CFM, if you can remember, chloramphenicol, fluoroquinolones, macrolides are lipophilic. Just remember LRTI, LRT, linezolid, rifampicin, tetracycline. Just to recall, these are the drugs which are lipid soluble. And the characteristic is they have a small volume of distribution and they're effective against intracellular organisms. And most lipophilic drugs depend on the liver for their excretion, and they are generally excreted by metabolism through the liver. So mainly the liver is the source of their elimination. So this is something you can just keep in back of your mind. So ABG is an acronym you can remember for hydrophilic drugs, and lipophilic, remember LRTI or LRT and CFM, so that just for you to recall. So this is the characteristic of drug. And how about protein binding? For most drugs, the antibiotics that you give tend to enter the cells freely, but most of them can be dependent on albumin binding. And the albumin binding of the antibiotic is directly proportional to the log of concentration of the albumin. And there are certain unique drugs that we use in ICU, which are not dependent on albumin, but they are dependent on alpha-1 glycoprotein. And some of these drugs are lignocaine, pethidine, phenytoin. So different drugs have different characteristics. So many antibiotics are albumin binding. Some of them freely enter the cell, and some of them depend on alpha-1 glycoprotein to enter the cell. And it is shown that these alpha-1 glycoprotein also increases in critical illness. And albumin, if it is less than, if the patient has a low albumin, very likely the free concentration of the drug, especially the albumin binding drugs, will be much higher. And large changes in protein binding will lead to very small effect in the free concentration. So although they are protein binding, so you really need to have a large changes in the albumin levels to have an effect to have a small effect on the free con. So basically what it tells you is you are, although many drugs may be dependent on albumin, but albumin deficiency not necessarily will have a profound impact on the free concentration of the drug because the effect is minimal. That's what is about the science we get to understand. So the practical applications is pharmacokinetics are needed for appropriate dosing. So if a drug is known to have a limited toxicity, then there is a room for you to give a large loading dose. And when a drug has a narrow therapeutic index, then a small loading dose has to be given. So, and maintenance dose are needed where your total body clearance is smaller, especially like the drugs like aminophylline, where maintenance dose has to be used if you have to attain the concentrations, the desired concentration. So what this simply means is, if you have a less toxicity, there is a room for a bigger dose. If your therapeutic index is small, then you cannot give a bigger dose. And for certain drugs where total body clearance is slow, there you have to give aminophylline, like you may have to give an infusion to maintain that. And there are certain drugs in ICU which have a very long half-life, like morphine and midazolam, where elimination half-life is around 3 hours. And these drugs, for them to attain a new steady state, it takes around 15 hours because they undergo 5 half-lives to attain a new steady state concentrations. I won't go into detail, but just bear in mind, some of these drugs have a longer half-life and they need multiple half-lives to attain new steady state concentration. So this is important in critically ill patients. Understand that the volume of distribution almost doubles. When volume of distribution doubles, the half-life of the drug also doubles, which means the drug remains in the body for a much longer time. And the total body clearance of the drug also does not happen. This is very important for all the trainees. Just remember, in critically ill patients, volume of distribution increases, half-life of the drug increases, and elimination of the drug also is slower. Everything becomes very slow. So the clearance of the drugs also will be how. So this is something we need to bear in mind. Okay, so just talking about pharmacodynamics and biophase. As I said, pharmacodynamics is the study of effect of drug on the body, and the biophase is the site at which the drug acts. And this pharmacodynamics, because it is the word dynamics, it's the metabolism of the drug and elimination. It is dependent on the circulatory situation of the patient or the circulatory or the blood flow of the patient. So if there is a low flow state, then the pharmacodynamics also tend to get affected. If it is hyperdynamic state, then the pharmacodynamics get affected. And pharmacodynamics also involves the site at which the drug acts. That's why it is important at the receptors. The expression of receptors at the site at which drug acts also has a bearing. Because I'll show you certain situations where there is underrepresentation of the receptors. So in some situations, there is overexpression of the receptors, and they also have a bearing on the pharmacodynamics. And there are certain drugs like morphine and midazolam where they automatically diffuse and they are not dependent on certain blood flow. So there can be diffusion independent of the blood flow, and that is something which we need to bear in mind. And there is this dose-response relationship where the effect of the drug is directly proportional to the log of concentration of the drug. So just pay a small attention. So the drug concentration until certain phase, the response would be minimal. Then there is a sudden small change in the concentration of the drug leads to a very large change with regards to the effect. And this tip off is what we call as therapeutic index. So it is the minimum therapeutic dose divided by maximum effective dose is what we call as the therapeutic index. So as you see, it is like a Starling curve, or so where at certain concentration of the drug, the effect gets very pronounced, and that effect is calculated as therapeutic index, which is calculated by minimum therapeutic dose divided by maximum effective dose. And there are certain drugs which we use in ICU which has a low therapeutic index like aminoglycosides or aminophylline. And then when we talk about dose response relationships for all our intensivists, this is the curve which you need to bear in mind when we talk about antibiotics. So whenever we administer antibiotics, there are few things that antibiotic effects are dependent on. You need to know the minimum inhibitory concentration, and one needs to know the time above MIC. So the time above MIC at which the drug is effective, and the peak concentration in the area under flow. So these are the four terminologies every intensivist should bear in mind. Minimum inhibitory concentration is the concentration at which the drug is antibiotic is potent, and the time above MIC is when the potency of the drug is maintained, and the peak concentration is there are certain antibiotics which have potency at the peak of its concentration, and there are certain antibiotics which are effective under this area under curve. So I'll just take you through these principles. So the time above MIC is represented as percentage, and it is desirable it should be more than 40%. And when we talk about all this, the maximum concentration divided by minimum inhibitory concentration should be more than 10. And there are certain antibiotics which are dependent on maximum concentration divided by MIC. And these are aminoglycosides, daptomycin, and fluoroquinolones. So they are dependent on concentrations divided by MIC. And there are certain drugs that are influenced by area under curve, which is this curve divided by MIC, which should be more than 100. These are azithromycin, tetracycline, and vancomycin. So these are influenced by area under curve divided by MIC. And the commonest drugs in ICU, which we use, are dependent on time above MIC. I'm sure most of you would be aware. So which are cephalosporins, penicillins, and carbapenems. So these are the ones which are that's why we give these drugs as infusions. The reason why we give an infusion is so that we give it as a prolonged infusion, because for that amount of time that we are able to maintain the drug above the minimum inhibitory concentrations to be potent and to be more effective. So remember this, these are the three terminologies which all of us should know. So AUC divided by MIC are all these macrolides, vancomycin, and tetracyclines. But and the time above MIC is penicillins, cephalosporins, carbapenems. And peak concentrations, very easy to remember. It's always aminoglycosides, fluoroquinolones, and daptomycin. So just we'll quickly talk about what are the changes and why these are important in critical illness. And I'm sure most of you know that we avoid administering any enterally administered antibiotics in ICU. Why do we do it? Because in critically unwell patients, there's alteration in the pH of the stomach, alteration in the function, alteration in the mobility, alteration in the gut perfusion, and then there can be delayed in the gastric emptying. And all this I have a potent bearing on any of the actions of these drugs like opioids or anticholinergics, phenothiazines, or so these are the drugs which are affected. So that's why we tend to give intravenous, because oral administered drugs, PKPD, becomes very unpredictable. And intramuscular administration of the drug also in ICU is not very well encouraged because of uncertainty of PKPD. So when we are giving intravenous, certain things need to be kept in mind, that glass syringes should not be used, because certain drugs like heparin, insulin, and isosorbide, their PKPDs get affected when you're using glass syringes, and plastic syringes has to be used. And there are certain drugs that should not be mixed, like calcium, propylene glycol, or thiopentone, because there is incompatibility with certain drugs. So basically, you need to bear in mind there are certain drugs which cannot be mixed with each other, and there are certain drugs which cannot be used in glass syringes. And when you're using infusion pumps, one needs to be aware, if you're going for a dose less than 1 to 2 ml per hour through infusion pumps, that also can become unreliable. So these are some of the things that needs to be kept in mind. So the quintessence is oral administration is discouraged in ICU because of the changes in the gut perfusion and pH and so on and so forth. IM is unpredictable in intensive care. When we are using intravenous, glass syringes to be avoided, and certain compatibility of certain drugs have to be borne in mind when you are using. So in circulatory failure, so when someone is in hypovolemic shock or septic shock, one needs to bear in mind that the blood flow to two organs get they tend to increase, which is the cerebral blood flow and the cardiovascular blood flow increases. But as a compensatory, the blood flow to liver and kidney tends to reduce in circulatory blood flow because the central sort of a circulation gets more preference. So your cerebral blood flow and cardiovascular blood flow increases, but there is an impaired blood flow into the liver and kidney. That's why you would see any hypotensive patient, the first organ that tends to take a hit is the kidney, and then later the liver tends to get affected. So so in circulatory failure, it is shown that the volume of distribution comes down, steady state distribution comes down, total body clearance comes down, and this have a bearing on when you're using sedative drugs or lignocaine. And there is volume of distribution can increase in situations and distribution half-life can go up. And when there is a circulatory shock, there can be acidemia that also can have effect on the peripheral resistance. And as I said, there is increased sensitivity of certain drugs in the shock situations, especially the CNS depressants. So if you're using sedatives, they have profound effect, and that's why you would have to use it in caution, especially in circulatory failure. So we'll just look into what are the PKPD changes in hepatic failure. In hepatic failure, your volume of distribution and total body clearance can go up or can come down. Elimination half-life is usually increased, and the phase 1 metabolism gets affected because of cytochrome P450. And impaired LFT has a poor correlation with the impaired metabolism of the drug. And when there is an increased bilirubin, it is shown there is a reduced albumin binding of cephalosporin, sulfonamides, penicillin, or tetracycline. So when liver dysfunction, the protein binding of certain antibiotics tend to get affected. And when the hepatic blood flow is decreased, then certain drugs like lignocaine, midazolam, and morphine metabolism can be affected. And there are certain drugs which are excreted through your biliary tract, like tigecycline. So they also tend to get affected, especially when tigecycline is being used when there is a liver dysfunction. And alpha-1 glycoprotein also levels can be reduced because this tends to bind to erythromycin and lincosamide, especially in situations where volume of distribution is high or clearance is reduced. So these also tend to get affected. So PKPD changes, so we spoke about in circulatory failure, liver failure, and in renal failure, volume of distribution can be higher and steady state volume is higher, half-life is higher, and total body clearance is low. Like I said, in hyperbilirubinemia, binding of antibiotics to albumin is reduced. In uremia also, binding of these cephalosporins, penicillin, and sulfonamides is reduced. So binding to the albumin tends to get affected. And creatinine clearance is a poor guide. Reduced GFR, it affects the metabolism of aminoglycosides. And morphine tends to get accumulated in acute kidney injury by the metabolites that get accumulated, which is morphine 6 glucuronide. And RRT also alters your total body clearance. In SIRS, again, your volume of distribution is high and you need higher loading dose. And during recovery, your volume of distribution tends to come down, which increases your vancomycin levels and midazolam levels. So I was just mentioning about changes in the receptors in acute illness, but as you see, there can be upregulation of the receptors in acute illness, and there can be downregulation of these receptors. And sometimes there can be proliferation of the acetylcholine receptors in acute illness. And there can be reduced affinity of catecholamines to these receptors, especially in acidemia and in hypothermia. So very simplistically, although it appears complicated, just bear in mind. So renal dysfunction, liver dysfunction, and SIRS response, the whole of volume distribution gets affected, and it can have bearing on multiple drugs that you would use. So augmented renal clearance is a concept one needs to bear in mind in critically ill patient. As I said, the creatinine clearance sometimes can go up, and which leads to subtherapeutic concentration of the drugs. And this was first conceived by Udi et al. In 2013, where they looked at 71 patients young patients with sepsis and trauma, and 57.7% of the patients had augmented renal clearance. And in sepsis, and most of them, as you see, 39.5% in sepsis patients had ARC, 85.7% in trauma had a ARC, and many of them were males. So the typical patients where there is increase in augmented renal clearance are young patient with hyperdynamic state, with sepsis or burns, and Apaches where they are not very, very sick, lower Apache, and and all these patients had high cardiac index. So the way it works is, so you have this inflammation, infection, burns, pancreatitis leads to SIRS, and this leads to vasodilatation and increase in the cardiac output. And this increase in the cardiac output can be accentuated by the fluids that we give or the vasopressors we give. And both of these leads to increase in the renal blood flow. And this increase in the renal blood flow increases the GFR. And this increase in the GFR leads to augmented renal clearance. Augmented renal clearance, simplistically, kidneys are become hyperactive and they are metabolizing the drugs and excreting the drugs much faster. And this typically happens in trauma patient, burns patient, or septic patients, young patients who are not very, very sick, but who are sick, where kidneys are hyperactivated. If you remember that, that is good enough. So when we talk about optimizing initial dosing of antibiotics, so there was a study by Australian group which showed that 70% of the antibiotics that we use in ICU achieved inappropriate concentration, especially with beta-lactam. Only 50.4% of them showed sort of a higher concentration, and 23.7% achieved subtherapeutic dosages. And there was another study by Belgian group where they showed only 28% of the patients in ICU attained day 1 PKPD targets, only 16% attained the targets, and 44% attained day 1 PKPD targets. What it is telling us is, whatever dosing we are giving, many a times in ICU, it is so dynamic that they may be attaining subtherapeutic concentrations on day 1 because of a lot of PKPD changes that tends to happen. That's why this whole concept of a loading dose comes, because their volume of distribution is high, elimination is low, and the steady state concentration they attain is lower. So there is a front loaded dosing, which means you give a high loading dose and then you maintain a some sort of a maintenance dose to attain that concentration because of all the changes that tends to happen. So again, the same thing. So for increased bactericidal effect, one needs to need continuous infusion. And when you're using vancomycin, bear in mind nephrotoxicity that can tend to happen, and one needs to do therapeutic drug monitoring, because at 20 to 30 micrograms per ml, if it exceeds, nephrotoxicity tends to set in. So summarily, when you're giving loading dose, so one needs to understand, if there is an increased volume of distribution, you need to increase the loading dose. If the reduced volume of distribution, you have to reduce the loading dose. And when you're talking about metabolism, if there is a hepatic dysfunction, when there is an increased metabolism, you have to increase the drug dose. When there is reduced metabolism, you have to reduce the drug dose. When it comes to excretion, if you have an acute kidney injury with reduced excretion, you have to reduce the drug dose, increase the dosing interval, or combine both. If there is increased excretion, as in augmented renal clearance, you have to increase the drug dose and reduce the dosing interval or combine. So this is how you can sort of approach. So initially, in critically ill, volume of distribution is always large. That's why summarily bear in mind that you have to give a loading dose. If you have a liver dysfunction and metabolism is impaired, then you may have to reduce the drug dosing. And if you have an acute kidney injury, you may have to reduce the dose and you may have to increase the dosing interval. So principally, that's what we keep doing every day in ICU. So summary and take home is, we understood that in ICU, oral drugs are a big no. We have to use IV drugs because of a lot of gut changes and unpredictable PKPD changes that happens. And please understand, most drugs that we use have narrow therapeutic index, and critically ill patients have altered PKPD, and they are very different to normal or ward patients. And response to drugs in critically ill patients changes based on their hemodynamic status, based on the organ dysfunction that is prevailing in these patients. It is important to monitor the effect of the drugs regularly in these intensive care patients. And please remember, when ICU patients are on hemodialysis or extracorporeal, that has a whole different bearing on your PKPD characterization of the drugs, and you have to optimize the drug dosing accordingly. So that's about it, folks. So thank you one and all. So I invite all of you to the signature conference GIGS that's happening from 18th to 20th October. So I invite you to submit valuable work in the Journal of Acute Care. So thank you one and all.